a great deal of pleasure to introduce our next speaker, a man who has a smile that goes from France to Senegal, from Detroit to Paris, from Paris to Bangalore. Dr. Khaled Ezzedine, MD, PhD, gained his doctorate in medicine in 1998 from the Free University in Brussels. He's also a professor of dermatology in Paris, France. He's a clinician and a full professor at the Henry Mondor Hospital. He has a long-term experience in ethnic dermatology. He spent time in Senegal, as well as the Middle East, and his research topics involve quantitative epidemiology, and he's developed multiple quality of life scales in dermatology. He currently leads our global program in vitiligo outcomes at Voice, which is part of C3, the Cochrane collaboration. And since 2021, he's been the head of the methodology section for C3. That's overseeing all methodology for all dermatology outcome measures across the world. He's participated in multiple workshops. He has done incredible work. He's highly, highly published. He's one of the top people published in dermatology. And he's also done numerous collaborations. Recently, he was the first author on the legislative paper that came out on the use of an oral JAK inhibitor. A very close friend, a wonderful collaborator, and an excellent educator. So I'd like to welcome Dr. Ezzedine to the stage, and he'll be talking about the burden and quality of life in vitiligo. It's one thing to talk about the pain of vitiligo, it's a whole different thing to measure it. So Dr. Ezzedine.
Thank you very much, Altifat, for this introduction. Thank you for inviting me and for giving me the privilege to be here, which is my pleasure. And I also want to deeply thank Davinder Prasad, who organized this conference with you. So I will speak today about the global burden of vitiligo and the psychosocial impact of vitiligo. I think that behind the name vitiligo, there are patients, there are men and women that are suffering. I think it's important to evaluate this burden of suffering of those patients. And these are my conflict of interest. I will maybe just give you the macro of this presentation. I will discuss first the prevalence, then the factors that affect quality of life, then those related to stigmatization, then those related to anxiety, depression, low self-esteem, and specific instruments that measure the burden, the quality of life in vitiligo. And I will conclude. So the prevalence of vitiligo. It's quite easy to say, this has been said thousands of times. 1% worldwide, earliest and larger epidemiological survey performed was on the Isle of Bornholm in Denmark in 1977, where they took the whole population in this island and they evaluated the prevalence. But what is this prevalence? It's what we call a point estimate, and I will come back to this later. 0.4% almost of the population was affected. Vitiligo affects ethnic groups and people of all skin types with no predilection. However, there are large geographic differences. In a study in the Shanxi province of China, they reported the prevalence as low as 0.09, whereas region of India rates as high as 8.8%. Why this? This is probably due to the inclusion of cases with chemical and toxic depigmentation, but not only probably, or the prevalence of a single institute in Delhi. Moreover, this disparity in the prevalence data may be due to higher reporting of data in places where social and cultural stigma are common. And this is very, very important when we discuss the burden of a disease, or where lesions are more evident in darker skinned individuals. Vitiligo, this is coming from personal unpublished data, most commonly affect the hands, 85% of the patient, the wrist, 69%, the armpits, the feet, the elbows, the mouth, the face and the hands were the most troublesome body areas affected by vitiligo when you ask the patients. This is just the prevalence when you look at the body surface area. Almost 1/3 have less than 5% of body surface area affected. And 42% report 5 to 10% of body surface area affected. Almost 2/3 of vitiligo have an onset before the age of 20. Segmental vitiligo accounts for 50% of all vitiligo. All of this you already heard about it. But why this is not sufficient for the moment? Probably because the variation of the prevalence estimate may be caused by lack of standardized definition of what we are measuring. What is an incident case? Patient-reported versus physician diagnosis. What is a prevalence estimate? What is a point estimate? What is a point estimate is like today I ask all the people in this area, do you have vitiligo? And I have a point estimate at now, or a period estimate, a period I take 2 time between T1 and T0, and I ask for vitiligo diagnosis. Is it the same than the point estimate? No. Or is it a lifetime estimate? And those differences are very important when you are aiming to measure the burden of vitiligo. Why epidemiological studies are important? Methodological differences in study design may also be a source of variation between countries, and not only this exposure that we were discussing for India. Maybe there are differences in methodological approach. Estimate derived from small population samples leave uncertainty as to the validity to extrapolate those results to global population. The key is to harmonize global data via using a standardized approach to the collection and to the analysis of cases. Geographical variation in vitiligo prevalence may also be attributed to differences in genetic backgrounds, you know that, and maybe antigen exposure, pathogenic and environmental, we don't know for the moment, but we need to know. There are higher prevalence rates for vitiligo that have been reported, I told you earlier, in countries such as India. This observation is complex, and similar findings have also been reported for other autoimmune disorders, not only for vitiligo. So how can we tackle this issue? Maybe doing cohort studies is important, and a registry are important. Why is it important? Because these data will allow us to match patients. If you take cohorts, in France we have a cohort of 200,000 patients that we are, not patients, individuals that we are following, and in these 200,000 patients, we have those who have vitiligo, and we have those who do not have vitiligo. And it's important to have such cohorts because you can match your vitiligo patients with those who do not have vitiligo and then measure the comorbidities. For example, you obtain longitudinal data to investigate the mortality, the morbidity rates, using data collected over a period, and we are about publishing such data. Alongside of this cohort study can demonstrate maybe a trend in a B or multimodal age distribution of vitiligo incidence for early onset vitiligo, for example. There is a very nice paper published by Richard Spritz a few years ago in the GID, where he showed a shift in the age of onset of vitiligo, which is now probably later, because in a previous report we said that most of vitiligo come before the age of 20, where Richard Spritz were able to show that probably this age now is not 20, but probably 30. Why? How can we understand this? We need longitudinal data. We need data from cohort and from registry. In addition, this cohort study, if we identify an increase in prevalence of the disease, which is possible if you have an environmental factor that is inducing vitiligo, then you can search for associated risk factor and try to counteract this increase in prevalence and in incidence. It is anticipated that the findings from such study may have important implications, because you can say, okay, today my prevalence is 1%, tomorrow it will become 1.5%. How will I treat the patients? What are the priorities for healthcare and resource allocation in the country where the study has been done? Epidemiological study can be used to understand the causes and patterns of vitiligo, but also to describe quality of life. And not only in one country, because you know that if you are living in India, when the social stigma of vitiligo is very high, it's not exactly the same if you are living in Europe with phototype 1, 2, and you have vitiligo. So it's important to set up registries and cohorts in each country, not only in those countries who have the more resources, but also in countries where the resources are not here. We need to have registries, cohort in all countries, not only in European Western countries. We need it also in India, we need it also in Africa, we need it everywhere. This will help us to identify trends in healthcare, prioritize research needs, quantify the risks of major adverse cardiovascular event, for example, but not only the risk of solid tumor and lymphoma in patients who will be treated with drugs. Because don't forget that now we are in an area where we are coming to new drugs. There will be a need to see what are these drugs inducing other than repigmenting vitiligo. It's not a matter because it has been done with the biologic for other diseases, but maybe the risk is lower, for example, for cardiovascular events in patients with vitiligo, which will push us to more easily use the drug in patients with vitiligo. We don't know. We need those data. We need also to investigate the natural history of vitiligo, to identify those environmental factors that can induce this increase in the prevalence, in the incidence of vitiligo and its comorbidity. Together, the information that will be gained from this study can be positioned to quantify the financial burden to society and ultimately to shape the policy decisions. And I'm discussing this because later on the session, we will discuss what Professor Venkataram Mysore has pushed us to do with the ILDS, a global vitiligo atlas. This will be discussed later. Again, why epidemiological studies are important? Country-specific database offer rich sources and are essential for accurate assessment of vitiligo presence within each country. And within each country, we have to quantify the burden of the disease, the quality of life effect of this disease. However, we need multi-source data because each source will have strengths and we have weaknesses. Data that are coming from our clinic have strengths because we can demonstrate the impact, but we also need more global data. We need large prospective databases that are extremely powerful tools to provide cohort data, which, if sufficient, can be stratified into data sets according to sex, to age, to genotype, and to ethnic background. And this only can be achieved if we have collaboration between the countries. However, developing and maintaining this type of resource is costly, and access could be restricted to specific research groups, and this is what I was saying. This will limit the generality of the use. This is why we have all together to act to make it possible in every country. In contrast, public polls and population surveys, because you can estimate the prevalence of a disease using population surveys. They have the potential, it's quite easy, and you have the potential to compile valuable data cost effectively because it's not as expensive as for a cohort, but it can be a basis to build a cohort. However, don't forget that there are biases that could arise due to the variation of patient-reported diagnosis, methodology, and cultural differences. Because if your vitiligo is just self-diagnosed, it's not exactly the same that it has been diagnosed by a physician, and even if it has been diagnosed by a dermatologist, it's even better. And I will just give you where we are standing now, the publications of the different, of the prevalence of vitiligo. This is a review that have been published in 2012. It's an extensive in-depth review of prevalence data from more than 50 worldwide studies. But since 2012, a lot of new studies have been done. The prevalence of vitiligo ranges from 0.06%, it was in China, to as high as 2.28%. And you see that there are huge differences. This is another study, which is a meta-analysis published in PLOS ONE. This meta-analysis assessed the prevalence of vitiligo. They used 103 studies. The pooled prevalence from 82 population or community-based studies was 0.2%. And this is the main limitation of the study. They pooled population and community-based, which is not exactly the same. If I'm searching for vitiligo within a restricted community, and if I'm searching for vitiligo within a whole population, it's not exactly the same. The pooled prevalence of vitiligo from 22 hospital-based study was 1.8%. But again, I think that if you have vitiligo and you have phototypes 1, you are in France, I'm not sure that you will go to a hospital to get diagnosed. If you have vitiligo, even if you have less than 1% on the face, or even on the tips, and if you're living in India or in Saudi Arabia, I'm sure that you will go and consult, and this will increase the prevalence of the disease in those populations, hospital-based studies. So segmental vitiligo in most of the studies account for 5 to 16%. This is a study we published a few years ago that was conducted in France through a representative sample of the population for age, for sex, from 18 years to older. Of course, we didn't get the children. And in this study, we estimated the prevalence of a lot of disease, of which vitiligo was part. And what we found is that for atopic dermatitis, the prevalence was, here the prevalence is per 100,000 persons. You have to divide. So atopic dermatitis is 4.6, psoriasis is 4.4, alopecia areata is 1.04, and vitiligo was 0.5%. This is another study published from the US. It's a prevalence of vitiligo, and Amit has worked a lot on the study. This is for me one of the best studies that have been conducted for the prevalence of vitiligo among adults. And you will see why. And you see how complex is the diagram to diagnose vitiligo. Because vitiligo, if you just ask a patient who previously had melanoma and who had a vitiligo-like lesion, he will say, I have vitiligo. So in this diagram, we asked the patient, melanoma prior to documentation, no or yes. Okay? And you see that the diagram in context, I invite you to have a look at the publication. And what we found is for the diagnosed and undiagnosed combined, self-reported was almost 4%, and clinician aggregated was 0.76. Diagnosed, 0.7. So there is a difference then of undiagnosed. There are a lot of people who have vitiligo who are not diagnosed by a physician, but probably have vitiligo. And we look at the pictures of those patients with Amit, and we diagnosed vitiligo in some of those patients. Not all, but some of them were having vitiligo. Why they are not accessing to healthcare? I don't know. Probably in the United States, because the access to, there are probably several reasons. The access might be difficult, but also the skin phototype, if you have skin phototype 1, you can be less willing to go and see a physician. This is another study that has been conducted in the world, vitiligo prevalence across several countries. And here you can see that again, the total vitiligo prevalence in France was 1.2. And you have peaks like in Italy, and you are coming probably to areas where the skin phototype is darker, 3.1. When you come to the diagnosed, again, you have people who are diagnosed and those who are not diagnosed. So part of the vitiligo patients are not diagnosed, and this is probably something that we should look at carefully. Now I will come to the psychosocial impact of vitiligo. Just this story that had been told to me, and I'm sure some of you have already seen this, by a patient who was of Pakistani origin in UK, and he had 25-year-old. He developed vitiligo whilst in England, mainly on his hand, on his right forearm, and he was seeking advice on how he could have his right forearm amputated before returning to his country of origin. He said, I will surely be rejected by my family if they see my forearm. This is just to tell you how this disease can impact, the life of patients, and how we have to find solutions for our patients. Skin has an important role in our interaction with the world. Skin color is an important element of the perception of someone else. Vitiligo has a major impact on quality of life. It is not to said again. From the public perceptions, it will depend on the cultural background. It's not exactly the same in Europe, probably, and in Saudi Arabia. It can be confused with leprosy. In Africa, it is confused with leprosy a lot. Hippocrates has included lichen, leprosy, and vitiligo under the same category, and it is an important cause for the social stigma in some countries. I'm not saying the references here, we should be here, it's here. In the old Buddhist literature, patients with vitiligo are not eligible to get ordained. Islamic theologians consider vitiligo as a defect in the couple, allowing husband of the wife to divorce. In Rig Veda, an Indian book, it is written that persons suffering from switra and their progeny are disqualified from marrying others. And the one who wrote this, who did the research for this, is here with us. It's Yvonne Gauthier, and it was published in the book that was led by Mauro Picardo and Alain Tayer. And this is important to know. And probably even in the Christian, when you look at the legend of someone who is called Saint Julien l'Hospitalier, at the end, Saint Julien l'Hospitalier is a man who was a prince and who let all what he had to go and have a simple life. And at his hand, when he came to die, when the angel came to take him, he was supposed to have leprosy, but probably he didn't have leprosy. He did have vitiligo. So what quality of life refers to? Quality of life refers to physical functioning, psychological state, and social interaction with others, which encompasses subjective factors that impact quality of life, usually from the patient perspective. The first report of the impact of quality of life on vitiligo was in 1978, and many people in this study, they showed that many people were frightened and embarrassed by vitiligo. Discrimination from others, shame, depression, anxiety can lead to low self-esteem and social isolation. In these two different studies, in the study by Porsad, vitiligo has a major impact on patient sexuality. This should not be neglected. And we have shown that the involvement of the genital area is probably impacting highly quality of life. In another survey conducted among members of the UK Vitiligo Society, over half of the respondents acknowledge vitiligo moderately or severely affect their quality of life. What are the factors that impact quality of life? Probably age at onset, probably the skin phototype, not probably, surely the skin phototype, the extent and distribution as well. It's not the same if you are having vitiligo on hidden area and if you are having it on your hands or on your face. Vitiligo on exposed skin is associated with unpleasant emotions. Emotions related to the disease are the fear of spread, shame, insecurity, sadness, inhibition. All of these are higher in vitiligo that is on exposed area in this study published in 2009. Stigmatization is higher in patients with visible lesions. Lesions involving the face, the arms, the legs, and the hands were at higher impact on DLQI in those 3 studies. And the degree of stigmatization linked to cultural background. Unfortunately, in France, we do not have the opportunity to ask the patient from what is the ethnic background. So the only way for us to know that is to ask for the skin phototype. But in those studies who were conducted outside of France, you can see that the stigmatization is linked to cultural background. Repercussion on physical appearance. Probably that the factors that affect quality of life are also skin phototype, and we showed that the repercussion on physical appearance is not exactly the same in patients with dark skin phototype and fair skin phototype. In patients with dark skin, they showed that managing vitiligo on daily basis was a burden, whereas in dark skin phototype, they more say that their life would be very different without vitiligo. 2 studies here, one published in 1986 and another in 1996. In the first study, 50% of the patients with vitiligo reported that they had been stared, 16 reported rude remarks, and 13 had job discriminations, and I'm quite sure that it's much higher than this for job discrimination. In a study in more than 600 patients, 59% report having feel bad because of the vitiligo in the past 3 weeks. This is another study that looked at the stigmatization and avoidance behavior and difficulties in coping with vitiligo. It's a study in 96 patients with vitiligo and controls. They asked for the DLQI and the adjustment to chronic skin disorders questionnaire, the back and the depression inventory. They found that stigma was reported in almost 90% of the patients, and that almost 1/4 of those patients reported nasty comments. They avoided situation because of vitiligo in 2/3 of them, and 2/3 of them implied psychological stress as influential on their disease course. It's an infernal loop. You have vitiligo, you are stressed outside because of your vitiligo, and your vitiligo develops more and more. Patients with vitiligo scored higher in all questionnaires and controls in the study, and they have more anxiety, more anxious depressive mood. This is another study that has been published in 1984, where the self-image was considerably decreased, with mood disturbances being common, particularly in teenagers. Vitiligo that begin in childhood can be associated with significant psychological trauma that may have a long-lasting effect on personal self-esteem. In children, it will impact even his adult life. Vitiligo patients are extremely receptive to emotion. They are prone to anticipate being rejected. Many report cruel and embarrassing comments from strangers, but also from close friends, which is more important. Porter et al. Identified 1/3 of the patients as poor adjusted and extremely depressed, with several depressed clearly linked to suicide. And all of you, if you have patients with vitiligo, you have been facing this problem of suicidality in your patients. Vitiligo is associated with important psychiatric comorbidity in 25% of the patients attending the clinic in this study conducted in India. This is a systematic review that looked at vitiligo and depression. The prevalence and risk of depression among patients with vitiligo. This was a cross-sectional case control or cohort studies that were assessed in this study. They assessed 141 studies and they excluded 95 of them, so they worked on 46. And 25 studies with 2,700 cases of vitiligo. The pool prevalence of depression was 0.25. You have a prevalence of 0.25. It's huge, the risk. It's a risk multiplied by 4. The pool prevalence of depressive symptom also was multiplied by 3. The pooled odds, when you look at the inverse for vitiligo, was 5.05%, 5.05 when you compare to controls, and patients with vitiligo significantly more likely to suffer from depression. The prevalence depends on geographical regions, and this is why it is important when you are doing studies to do it in all the continents, not only in one part of the continent. The pooled prevalence of depressive symptom increased from 24% in Europe to 33% in Asia, Africa, or the Middle East. And the pooled odds ratio of depression ranges from 1.3% to almost 8%. Clinicians
So,
should actively
Khaled, we
evaluate-
should probably do one more slide.
Okay. I will go quite quickly then. And just present this slide, this last study on the quality of life assessment in childhood in a tertiary care center in Vitiligo, a cross-sectional study where they used the child DLQI, 114 patients, and the impairment was higher in older children, which is normal. And I would not discuss the specific instruments of vitiligo, but this is probably the best one to date. This one has been validated most of all the other scores in vitiligo. There are 4 different scores, and I invite you to have a look at this study, which is a systematic review. Thank you.
So just in the interest of time, maybe you will take one question, but thank you for the excellent review. Wow, from our vitiligo community back there, so. Okay, please. This is such a critical lecture. I hope that you got a lot out of that, and then we'll...
Good morning, everyone. Thank you so much, Dr. Khaled, for the detailed presentation. If you may allow me. One thing that I like actually is the quality of living with vitiligo. And then I like how you broke down the emphasizing of having studies in different countries and continents, right? So I will speak about Central Africa, Southern Africa, because I'm from South Africa. And then also maybe West Africa. The financial impact of patients being able to continue with treatment on vitiligo is quite high, because not everyone has the privilege of having medical aid. I think in other countries it's called health insurances or medical insurances. So there is a lot of treatment relapsing because one cannot continue with the treatments because the cost is becoming too high. So I think this study of quality of life and the burden of living with vitiligo, it's one of the studies that are close to my heart, because I believe that representation for countries and continents is quite very important. I wish we had enough time for the presentation to continue. Hopefully we'll see tomorrow if we can add more in there. So thank you so much.
Maybe in the next presentation I will be discussing this as well.
All right, thank you so much.
So maybe what we can do is, Dr. Alisa, do you have a quick question?
It is just very, very, very interesting. One of my government, he say, Ahmed, you have 2 different messages. From the support group, you say it's not a disease, it is just a color, so live without anything. And this is just, even you don't call them a patient, you call them a client. And we are emphasizing our support group. At the same time, you're asking for huge money for biological therapy and for the JAK inhibitors. And so this is a disease that needs no treatment like your support group message, or you need a huge money fund for research. And so how can we make our message to our government really clear here?
I think that just we published with the Global Vitiligo Foundation group, the Vitiligo Working Group at that time, a paper, an editorial in the Journal of the American Academy, where we discussed in 10 points why vitiligo is not a cosmetic disease. It is a true disease because it's associated with autoimmune comorbidities, and for several reasons. I invite you to take this paper and go to the
Khaled, all the support group, they say it's not a disease, those are client and they are not a patient, live without. So I think we have to have the message. I mean, we talk to each other to make it clear to our government to say, do they support or they just to live without treatment?
Good questions, and we have to the disease, and we'll be talking about that at lunchtime quite a bit. I'm going to hand it over to my colleague.